Ladies and gentlemen, my name is Pyeong HWANG, team moderator of this forum and deputy director of Chronic Disease Control Division of the KDCA. Before we begin the forum, I would like to quickly go through the program as follows. The forum will be opened with congratulatory speech by Professor No-Yai PARK from University of Inje, and continued with 5 presentations focused on health inequality issues. For the next, the panel discussion will be proceeded. This forum will be ended by the ending remarks by the chair. Ladies and gentlemen, we will begin the forum titled Strategies to Tackle Health Inequalities at the Community Level and Best Practice. First of all, Professor No-Yai PARK from Graduate School of Public Health Inje University will deliver congratulatory speech. Professor Park has devoted her lifetime to training professionals in Korea public health sector. Furthermore, as a representative of survey institution of the Korea Community Health Survey, she has a wealth of experience and insight in community level of public health in Korea. Ladies and gentlemen, please welcome Professor Park.
Good afternoon, all of you. It is very nice to see such a beautiful city in Songdo. I am No-Yai PARK, distinguished professor in Inje University School of Public Health, also the cooperation director of the community survey conducted by Korean Disease Control and Prevention agencies. First of all, I would like to welcome both national and international participants, those who are interested in Health City Forum, Community Health Disparity Discussion Session. And then, in addition, I would like to thank Dr. Yeon-Chul Hong, chairman of the Health City Forum, and Dr. Rim SHIN, who served the moderator of this afternoon 2 sessions. And also, I'd like to thank Hopyeong HWANG, director of the Chronic Disease Division, KDCA, and Sun-Jin Jo, professor Ewha University, Kwang Kee KIM, Inje University School of Public Health, Naoki KONDO, Kyoto University from Japan, Dr. S.P. SUBRAMANIAN, Harvard University from USA. And they are so to detailed presentation in this afternoon. I thought, and next, but we have so many disparity programs. Also, discuss about this afternoon, different way to this. I think we have many disparity programs. For example, the disparity of the programs and present situation is distribution of the healthcare facility and manpowers, quality of the care, accessibility program, when we have an extent situation, preventive education to the general public, level we are very poor, some areas ineducated. For example, Republic of Korea, we have 69,570 medical care facilities around the country, but still people are struggling to complain about accessibility program. They get the extent situation. That's why we are here to discuss about those programs. But there's a will, there's a way. We are willing to solve this, so there's a way. I always like Aristotle's quote, well begun is half done. In this sense, today's health city forum will reduce half of the community disparity, and it became a keystone. I hope today's meeting will be most fruitful time in our life. Thanks again, and see you soon, Korea or any part of the world. Thank you.
Thank you, Professor Park. From now on, the first session of our forum, including 5 presentations, will be started and facilitated by the chair, Dr. Rim SHIN. Dr. SHIN was the director of NCD and health through the life course DNH for almost 3 years, including as the acting director of DNH, and was working as the coordinator of the NCD unit in WIPRO for 8 years. In addition, she has served as an advisory reporter for the Alliance for Healthy Cities since 2010. Recently, she is working at Korea Foundation for International Healthcare as a director after retirement from WHO WIPRO in 2021. Ladies and gentlemen, please welcome Dr. SHIN.
Thank you, Mr. Jung, for a kind introduction of me. Hi, everybody. This afternoon, we will have a session, as Professor Park mentioned, the strategy to tackle health inequality at the community level. And then we will have some presentation about best practices in Korea, too. Now, I would like to call upon the first speaker, Mr. Hopyeong from the Division of Chronic Disease Control Director, KDCA. Where's Mr. Hwang? Yeah, please. And before his presentation, I would like to say something about that. Our speakers will have 10 minutes for Korean speakers and 15 minutes for foreign speakers. And then we will have a panel discussion after the 5 speakers. Mr. Hwang, please.
Good afternoon. I am Kwang Hopyeong, the Director of Division of the Chronic Disease Control Division, KDCA. I would like to start my presentation with a quick introduction about the major division related to NCD control and prevention in KDCA. KDCA has the Department of Chronic Disease Prevention and Control, including 4 divisions. These divisions are working on national and community level health survey, chronic disease surveillance and analysis program, and prevention and management program for major NCDs, such as hypertension and diabetes. In addition, the National Institute of Health, which is a part of KDCA, also carry out scientific research on NCDs. The Ministry of Health and Welfare, MOHW, also play a key role for NCD control and management. The MOHW are working on health promotion, cancer control, mental health control, rare disease control, oral health, and CVD. Ministry of Education and Ministry of Environment also drive NCD policy dealing with adolescent health and environment health hazard issues. This slide is about the current status of NCD in Korea. As you can see, NCDs are the leading cause of death in Korea. Especially cancer and CVD are the first and second cause of Korean deaths. NCDs are causing economic burden too. That is about 82% of the total medical cost in 2021 came from the NCDs. Korea is one of the countries having high life expectancy, that is about 80-30 years old in 2020. However, healthy life expectancy of Korea is slightly over 70 years old. As you can see, around 10 years gap between two indicators exists in Korea. Due to this circumstance, KDCA has tried to find a way to reduce NCD-related national burden and improve quality of life among Koreans. For achieving this goal, KDCA has these 5 strategies. Especially, KDCA has the national and community level of health survey, namely Korean National Health and Nutrition Examination Survey, Korean Community Health Survey, KCHS, and Korean Youth Risk Behavior Survey to monitor Koreans' lifestyle and health conditions. I would like to explain about the KCHS more to mention community level of health disparities. In the 2008, KDCA started to conduct KCHS through 16 provinces and 251 countries, which are whole administrative area of Korea at that time. The objective of KCHS is to improve the level of community health and decrease health disparities among communities. We have also tried to support evidence-based community health promotion programs and policies by providing the KCHS data at the provincial and sub-provincial level. This is about the operation system of the KCHS. As you can see from the KDCS to around 1,200 interviewers, many organizations are involved in this survey. Here are the KCHS core questions for family and individual survey. The number of survey questions of this year was 145, and based on these questions, we produced 106 indicators such as current smoking rate or alcohol use rate. KDCA has published community health statistics at a glance, including health data of all provinces every year. The 258 sub-provinces also published their own community health statistics. The KCHS database-based information is provided through the website for a variety range of users. From this slide, I'm going to talk about the current status of health disparities that can be identified through the KCHS. The first indicator that I wanted to show you is the current smoking rate. When you look at the GIS graphic from 2013 to 2022, we can identify the current smoking rate has been improved. However, upper graphic tells us that the size of gap between highest and lowest rate is different over the 17 provinces. high-risk drinking rate has been similar pattern with the current smoking rate. And participation rate of physics activity has slightly improved over the past 10 years. Furthermore, we identified several provinces that has a huge gap between active and inactive sub-provinces. As you can see, the GIS graphics, obesity rate has increased in almost every provinces. Several provinces also show us a big gap between the sub-provinces. We believe that the local government make an effort to reduce health disparities that are identified through the KCHS data. However, many local governments could not resolve their problems for themselves due to the limited budget and knowledge issues. Because of this local circumstance in 2017, KDCA launched the project for supporting sub-provinces having low level of health compared to other sub-provinces. For the selected sub-province, KDCA and local government provide financial support. With this support, the sub-province try to find the cause of health problem, develop and implement on intervention, and assess the effect of the intervention. After finishing the 3-year support, the sub-province is encouraged to continue to program with their own resource. The project includes three types of model. The first type is to identify a cause of health disparity of the selected sub-province with a comparison group and develop an intervention program. The second type is to identify a cause of health problem in the selected sub-province through in-depth research and suggest an effective way to solve the problem. The third type focuses on Upmyeondong, which is the smallest administrative area in Korea. In this model, we can identify the cause of health disparity among the area and develop intervention to reduce the disparity. Since we started the project, a total of 42 regions have participated in the project. Among these, 20 regions have completed their project, and in 22 regions, the project is ongoing. Here are the key considerations for implementing the project. First, various community members should be involved in the project. This is because the community members are the most important resource to identify the cause of health problems and find solutions. Next, we need to build a linkage system among community, government, research institution, and keep operating the system for administrative and technical support. Lastly, it is important to support continuously the region completing the 3-year project for keeping on their project. For example, central government provides financial and technical support while local government provide the institutional foundation and try to secure the budget. Based on the experience and knowledge that we have had so far, KDC are going to focus on the third type of the project. This is because the third type is more effective model to make active participation of local government compared to the other two types. Also, we are going to provide technical support systems such as operating advisory group to local government. We're hoping to reduce health disparities. That's all for the explanation.
Thank you
for
Mr.
your attention.
Yeah.
Thank you.
Sorry that I interrupt you because of the time is over. And your presentation is very well, and because of our Korea's NCD or including any health survey, surveillance and monitoring system is quite excellent. And then he also including the future plans for the health disparity reduction project. Thank you again, Mr. Hwang. And now I would like to invite second speaker, Mr. Naoki KONDO. He is a professor of the Department of Social Epidemiology, Graduate School of Medicine and School of Public Health, Kyoto University from Japan. Dr. Kondo, please. Yeah. Could you keep the 15 minutes for your presentation?
Hi, good afternoon, everyone. Thank you for introducing me. So I'm Naoki Kondo from Japan, and I'm a professor of social epidemiology. So I would like to share some of the experience of Japanese government and local government and researchers' collaborative work about reducing health disparities. Okay, so as you may know, that the WHO recommend three things to tackle the social determinants of health issues and reducing health disparities. One is to improve daily living conditions. And to do so, we need to strengthen the governance and involving lots of non-health sectors as well. And to do so, we also need to conduct health equity assessment based on the measurement of the quantitative data about health disparity. So my talk is have two sessions, and one is about Japan's recent health promotion policies about reducing health disparity. And it's like a journey of 20 years of experience in Japan. And also we focus on the data-driven community-based interventions based on those national governmental policies. And also some, additional things to promote the community actions to reduce health disparity using some types of business models. This is too close to see my slides, so maybe I need to see this slide. Okay, so Japanese management of health promotion using the descriptive quantitative data started from 2001, when Japan started the Health Japan 21. And this year, the government started to set up 9 fields about the target of health promotion and start managing the activity by the quantitative data and setting the goals. And after the 10 years, so that first 10 years was not so much successful. So they couldn't achieve lots of goals. So why then the government at that time witnessed that new concerns for health disparity exist. So the next 10 years, so the government started to set up the goal, adding the goal of reducing health disparity in addition to the extending healthy life expectancy also. Just focusing on not only the average health, but also disparities. And to do so, the government stressed about improving the quality of social environment as well, in addition to just providing the individualistic recommendations to improve your health behaviors. After the 10 years, so the life expectancy constantly improved, and also the health disparity also reduced to some extent. But in the final committee for the second term, Health Japan 21, also said that despite the steady improvement in healthy life expectancy, but we still have some health disparities across prefectures. So we need to do more effective way of reducing health inequality. And the discussions concluded the more stress to making the good social environment. For example, like making more social ties or social capital, and improve the access to health promoting opportunities. Then improving the quality of the social environment, more stress on the environment, and making cities in which people can enjoy the healthy life in natural. So what have done in that kind of activities in the community settings? Before in the first 10 years, so the government and many local, specialists focus on the individualistic approach. So the first time it's like a more medical model. That means the identify the high-risk people by health checkup and provide some health-promoting opportunities like training or exercising or those things. But the older people doesn't want to be checked for their health status. Not so many people do so. So this kind of strategy doesn't successful so much. Then the government shifted the main strategy for more social model, so making good environment. And this is the current Japanese model and the central model for the older adult care, which is called the community-based integrated care system. So that is promoting the partnerships among care providers, citizens, and other community resources so that the local people can enjoy the healthy life within the community they are living in. The partnerships not only between the special care providers, but also the the local residents as well. Okay. So, for example, the current municipality government are very eager to expand this system, this activity. It's called Kayoi no Ba, or community salon programs. The volunteer older people run the community social gathering places by their own. And just the older people who are, for example, like living alone, can go easily to those community salons. Then just enjoy the social interactions. Not necessarily to do something, like a physical training or those things, just play games or crafting or those things. Then our intervention study revealed that participation in this community salon halved the risk for the long-term care needs. So that's the quite massive impact. So I was doubt about this, this is too big impact. So what happened? The secret was that the socially vulnerable people are more likely to participate in that kind of activity compared to the previously done, like training programs and those things. You can see that the low-income people are more likely to go to the salon activities. So that may be the reason, one of the reasons. So socially vulnerable people are likely to have more risk to be frailty. So this kind of activity can reach to those people. So that can contribute to the reducing health disparity. And the local government how local government manage this kind of activities. You cannot make the salons at the same time in all regions. So you need to prioritize the places for the intervention and supporting the local people's activities. So this is a case by the Kobe city. Kobe city is a huge city in Japan, and it's famous for the Kobe beef, so you may know the name of the city. And so the vertical, each row means its community district name within the Kobe city. And each column means some indicators, for example, like long-term care risks and community resources to address the risks. Then the colored those indicators by the rank. And then you can see remarkably that some areas have very high risk and low resources. So there is so much gap. So you can see that these areas should be prioritized for the interventions. So this is quite an easy way to show what you should be prioritize for the local municipality practitioners. They are very busy. So you need some good tool like this. This figure also shows another heat map showing the changes in the indicator by regions. You can see this area is quite bad about the achievement. So that you can see that this should be prioritized. So actually, for example, in the Matsuura city, this is a very small city in Kyushu Island. So the public health nurse made some attractive figure based on those data, community diagnosis that we call, and share the information with local residents. Then local residents noticed that there are so many people who suffer from, in this case, it's like frail older people and who are lonely, living alone at the area, and who doesn't have opportunity to go shopping, because this is quite very local area. There is no retail stores anymore. Then the local people started their actions by themselves and established a new salon program. So there are some spillover effect after that. Mobile shop was back. Before that, this area, there are depopulation, there are huge speed of depopulation, so the mobile shop stopped coming here. Then, after that, public health nurse called the mobile shop. So someday, for example, like every Monday, they have some social gatherings, activities in some public space. So you can come and you can sell a lot. Then, the local people enjoy shopping as well. So this is one case of a successful case, and we doubted that this, effective way of utilization can be the good model for all the municipalities or not. So we conducted some quasi-experimental study and published 2 papers. And the data was based on our project. It's called the Japan Gerontological Evaluation Study, which was a longitudinal study we started from 2010, involving more than 100,000 older people worldwide in Japan. And so we provided its so-called community diagnosis sheet for all municipalities that provides the information about the sub-regional level status of health conditions and social resources to address it, those things. But most municipalities cannot use this kind of data in an efficient way. So for the half of the municipality, we provided some extra support to utilize the community diagnosis data, and especially using the data to communicate with other sectors, non-health sectors, and discuss about what they can do for the local people and how to prioritize the regions for those things. For the latter half, another half, we just provided the community diagnosis data and see what happened for 3 years. And for some local area, this is another small city in Kyushu. It's called Mifune town. So the public health nurse have some, local committee, it's kind of town meetings with the local area and share the data with local citizens. And they also noticed the problems by themselves and started some new actions like this. The local citizens launched new activity for the community revitalizing community, a community revitalizing committee, like that. Then they started new salons. This area already had the salon programs, but still they have lots of older people who are living homebounded. It's like a social withdrawal status. Then they noticed that we need more, more fun type salons, so that can, invite more lonely people as well. Then they utilized the local abandoned primary school. That was the school that these older people went when they were childhood, and started new school-type salons. And in the lunchtime, they also provided school lunch, funded by the fund from another non-health sectors. It's like a farming promotion department, like that. Okay, let's go. Oh, sorry. And this kind of activity was also theorized by the community organizing, and it's called Community Coalition Action Theory. For example, in this time, the support agency supported one key sector which can promote the coalition across without various sectors. Then the members of the coalition can build more skills for policy planning, leadership assessment, and partnership building. Then collaborative synergy is emerging and developing, and community capacity is increasing, and some healthy actions are happening, and health equity can be achieved, like that. What happened after 3 years? The social participation of older people in the intervention community is increasing compared to the control communities. So the activity actually increased the social participation. And the important thing is that is effective not only for rich people, but also the poor people too, low-income people. And also the mortality reduced compared to the control group in intervention community in men. And similarly, the effect was not different by income levels. So far, anyway, so this data-based community building activity can be effective in reducing health disparities, or at least you can provide some effective intervention to socially vulnerable people as well. Then the national government tried to promote this kind of activity more, and now established a new incentivizing policy for the local government. And the central government asked the local community to send the performance indicators. It's like 30 or 40 indicators. And the central government calculates the total score and pay back according to the score. So the municipality government they like to provide the data and to get the incentive and the payment back. And the central government can manage what kind of activity is effective and controlling the local behavior by changing the weight of the performance indicators by its topics, or like that. So this is like a data-based, like a harmonized communication system between the central government and the local government. So we need better governance rather than the government. So a more horizontal way of the communication across organizations beyond the health sectors. And the data is quite powerful to connect those organizations making the governance. And the incentivizing program to promote those autonomic and innovative action is very important in my thinking. Thank you very much.
Thank you, Professor Kondo. I just wondering about when you showed your slide, you just mentioned the Health Japan 21 about the fourth term. But however, in the slide, you also include Health Japan 21 second term, 2013 to 2022. So is it a mistake or what does it mean that you just mentioned the fourth term Health Japan 21, not the second term?
It's second.
Yeah.
Sorry, that might be wrong. Yeah, that it was second term.
Oh yeah, second term.
Thank you.
And thank you. I also heard that you have a better result among the lower income groups, and then from the longitudinal study, you have a good outcome of the mortality. Thank you very much for your achievement. Thank you. Yeah, let's move to the third speaker. Dr. SUBRAMANIAN from Harvard University.
Thank you. Thank you, everyone, for coming to this session, and thank you to Professor Hwang and Dr. Joo for inviting me to this conference, and also to the Korean Center for Disease Agency for incorporating me into this session. Oh, do I? How do I move the slide? Oh, okay. So what I'm going to talk about today back. I aim here, okay. So I'm going to talk today about a program in India which was focused on, it was called aspirational districts. So out of the 700 districts in India, about 100 of them were selected for a more intense intervention. And I want to sort of just share some findings from that. How did that fare vis-a-vis the SDG indicators that currently we are mapping or assessing the progress of the same? I just want to acknowledge a few people here who were involved with this work. So broadly speaking, public policy practice, I feel, has kind of three questions that we tend to have to answer in one form or the other. One is, how do we decide which policy should be prioritized and which one should get focus, which one should be the one picked up for intervention, because there are so many issues and it's really important. So that's number one. The second is what populations should be prioritized for whatever we choose to be the issues. So, and then finally, whatever once we pick those two questions, and the substantive focus is on what should be the content of the intervention that we should sort of come up with to improve that particular outcome. In this particular talk, I'm just going to focus on number 1 and 2. Number 1 being the SDG indicators on population health and social determinants of health, and then, but mostly my focus would be on number 2. How to prioritize populations, and in this particular case, did a program work? So more specifically, I'm just going to sort of talk about two aims. First, to assess the progress on 33 SDG indicators. These are the Sustainable Development Goals indicators, largely from the domains of population health and social determinants of health in 700 plus districts of India. I'll talk about what these mean. And then additionally, I'm just also going to assess this one program that was started called the Aspirational Districts Program, and whether that improved these indicators at a faster rate compared to the non or other districts. So just to give you the audience who are not familiar with the Indian policy landscape, district as a unit is a very important unit in India. There are about 722 of them. And each district is headed by a sort of a CEO, you could say, who's appointed, okay, through the civil service. So they pass civil service exams, a very difficult exam, and then they join in, and then they eventually become the district collector or magistrate. Think about them as the district CEO. They're in charge of that district, from everything from law and order to delivering on development. So there's a very powerful unit and office, and that is also the unit where it's the sort of the most decentralized form of administration. So there is a central administration, there is a state administration, and right down at the district level, there's a full-fledged administration. So it's a very important decentralized unit, and it is also at that unit where the district CEO could look at some national programs and accordingly customize based on the needs for the population. So it's a very important unit. Of course, in the case of India, you can imagine there are about 780 districts, and districts keeps getting created for more efficient governance, etc. But still, on average, a district will have about 1 million people, about 1,000 villages, so in the case of a rural area. But at the same time, it's still a very useful unit because it is extremely influential and powerful. So of those 782 districts, the current Prime Minister of India, under his administration launched this program called the Aspirational Districts Program. And the idea behind the Aspirational Districts Program, as it's said in the first bullet point, to quickly and effectively transform about 100 plus most underdeveloped districts across the country. And they broadly focused around 4 areas: health and nutrition, education, and they were clearly informed at that time by the broader SDG framework of which India is a signatory. And we had a data set that 2 waves of data set on the same districts, so it gives us a very unique opportunity to see whether an area-focused program, a very comprehensive, integrated area-focused program allows to gain some momentum to achieving the goals. And I'm not going to go into detail. We have about 33 SDG indicators. They come from the Demographic Health Survey data. The indicators themselves are about 33. They come from about 9 SDG goals. So one of them is no poverty. We have 3 indicators within that. We have also indicators under zero hunger, which is SDG 2 covered. We have a bunch of indicators under the good health and well-being on the third SDG 3. We have also, on 4, we don't have anything in the data set, but SDG 5, which is explicitly on gender equality, we have few indicators. And then on clean water and sanitation or access to basic services, we have those few. Energy, affordable and clean energy, we have a couple of variables from that. I think the last 2 are decent work and economic growth, SDG number 8, and finally 1 indicator from the SDG 16. So of the 17 SDG indicators, there are 200 of the SDG goals. There are 200 plus indicators. We have 33 of them from these 9 SDG goals. That's the last one, sorry. So there's one on SDG 17 as well, on connectivity. Okay, I'm going to skip through this slide, the next 3 slides. Basically, we have 2 waves of data, and we had to do certain things to make them comparable, et cetera, et cetera. So I'm going to skip through that and basically say for each district, we were able to assign a status. Okay, and a district could fall in one of the 4 categories on a given indicator. So we could say that on a given indicator, a district could have already achieved it. So that's achieved 1. By 2021, they have already achieved the target. And they will stay achieved in terms of the status by 2030, based on how they performed in the last 5 years. Achieved 2 are districts that have achieved the target by 2021, but in the last 5 years, they experienced a decline, like a worsening. So that status can get undone. That's achieved number 2. And then we have a third set, which is a district is on target based on what happened in the last 5 years and their current levels to meeting the target by 2030. And then finally, we have the district that could be off target. They have not met their goal in 2021, and based on the last 5-year performance or change, they are unlikely to meet. If that stays the same, they will not meet the goals in 2030. For those districts that are not meeting the goal by 2030, we additionally also computed when will they meet the goal, so by 2035 or before, or after 2035, and so on, as you can see. Just to give a sense of how close they are, because 2030 is a random, arbitrary year. So if some districts are achieving by 2035, probably it's okay, or 30. But if they are achieving well after 2041, then clearly something will have to be done immediately. Okay, so that's the background. And what's the quick report, one at the all India level? So there's only of the 33 indicators on one of them, which is adolescent pregnancy. So the number of girls, proportion of girls who have become pregnant at a very, very, very young age, which is 10 to 14. India has already achieved, as a nation, as a country, that particular goal, and they will stay achieved based on the last 5 years. About 13 of the indicators are on target to meeting the goals by 2030, and they kind of range in various goals, but by and large, they relate to things like improved sanitation, birth registration, neonatal mortality, that's an important one, under 5 mortality. So this is not for just for overall India as a country. Multidimensional poverty, they are on track if the last 5 years are an indication. On the remaining 19 or so indicators, India is off target. They will not meet the target as a country on all these indicators. And a big chunk of these indicators relates to gender equality related indicators and also nutrition related indicators. As you can see, we have things like anemia or stunting or wasting and overweight and so on. And on the gender equality side, we have like partner violence, child marriage, and so on. And also some health, like the health insurance and so on. And this I'll just skip. When will they meet? And for some of them, it's really far out in terms of where India stands currently. Obviously, as you can guess, just because a variable has a status of achieved or on target for India as a country does not mean that all districts in India have that status. Because you can achieve the all India status just by focusing on the good ones, because I can keep putting money and the average will change. But so what I want to show you is the variation. What you see on the column are the 33 indicators, okay? And what you see on the x-axis here is the number of districts. So there are about 700 districts, as I said, and this is the count of the districts, and I have just sorted the data in terms of the count of the districts. So if you go from the top to the bottom, the more green means a vast majority of the districts are on target to have achieved or they are on target. Those are the greens and the blue, but if there's a huge red, then vast majority of the districts are not on target. So just as a sort of an example, if you take neonatal mortality, it's somewhere in the middle. Like, as I said, India is on track to be meeting its goal on neonatal mortality, but almost 250 districts in India are not on target for meeting neonatal mortality. which is a very basic indicator, or for that matter, even under 5 mortality. The pointer is not working, but you can see. So here is one sort of deep dive example of multidimensional poverty. That's the map of districts of India. And as you can see on multidimensional poverty, a vast number of districts have achieved or on target. And the red ones are the ones which are off target. But as I said, if you look at neonatal mortality, even though India is on target for a vast majority of the districts, they are completely off target. But again, as the previous speaker, Dr. Kondo, mentioned, these kind of sort of maps could help. Where should the money be focused? So that's sort of one. And there are some other sort of insights that we got. So think about for each of the district, they have potentially 33 indicators for each one of them. And this is a map of the percentage of indicators that are achieved in a given district. So as you can see, there is not a single district in India where all 33 have been achieved. The maximum it goes is 13, which is in the state of Kerala and South. And this gives you the percentage of SDG indicators that are on target. And again, in no single districts, all 33 indicators are on target. The highest it goes is 23 out of 33. And finally, if you look at the percentage of indicators that are off target, again, with a denominator of n of 33, there are some districts where 27 of the 33, these are the top 5, top 4, they are off target. So if you have to really, really see which districts to pick on a broad collection of indicators, then these 4 would be the candidate districts for those. So the last part of the thing is, so did the aspirational districts program work? That's the story for all India, all the districts. So aspirational districts, just to sort of give you a sense, there are about 100 of them. So this is a picture of just not 700, it just goes to 112, which is the number of aspirational districts. And the percentages looks more or less similar to overall distribution. Let me show, probably this is more meaningful. What's shown here on the column are again the 33 indicators. What's shown on the left panel, which says AAC aspirational districts, that's the annual change that happened in the last 5 years for aspirational districts, and the annual change that happened for the other districts. As you can see, on any given indicator, there is a more or less a very similar change that we observe. Okay, with a wide distribution around them, suggesting that the rate of change was not any faster in the aspirational districts compared to the other districts. And these are the aspirational districts in terms of their location. In terms of neonatal mortality, as you can see, there are aspirational districts that are on target, but there are also aspirational districts that are off target. So you can see the variability in that. And I compare that aspirational districts to the other districts. So you can see that almost 50% of the aspirational districts are off target, while for the other, it is only 38. So the program does not seem to have made a huge difference to the aspirational districts. And this is on multidimensional poverty. Again, you can see that 16% of the districts are off target amongst aspirational districts, while only 4% are off target on the other districts. And here I have just shown for the multidimensional poverty, in part, that's the annualized change on the y-axis, how much they changed. And as you can see, in many aspirational districts, when it's negative, things became worse. So there are aspirational districts that became worse, and some became better, you can see. And the same thing, we find a much wider distribution for the other. This graph plot I'm showing, because these are 2 years, 2016, 2021. In 2016, the distribution for aspirational and other districts, and in 2021, the distribution for aspirational and other districts. And as you can see, at baseline, the aspirational districts were not worse off. Actually, it was very broad. It was almost like a representative sample of the districts rather than underdeveloped districts. So one point that I want to make is the choice where you do intervention really matters. It's like if you're doing a drug intervention on cholesterol and then you don't have patients who have high cholesterol, that does not make sense. It's usually done, so getting the right population or the right district or the selection of the districts is very critical. And this just shows for the aspirational districts, baseline multidimensional poverty in 2016 and change. And for the other districts, so districts with high rates in baseline experience bigger change, but the rate of change is pretty much the same for other and aspirational districts. So no very strong, compelling pattern that aspirational districts work. For some it worked, some it did not work. So there was a bit of a heterogeneity there. This is a paper under review, but we have a kind of a dashboard. We just put all the data that we have to visualize on this Power BI. So if people are interested, you can just look at it and explore any given variable that you might be interested in. Just final slide, some reflections. So I think like when we are thinking about selecting areas for intervention, whatever that might be, I think there has to be some thoughtful input on how to select these districts. And I think this has to be somewhat of a more involved exercise rather than just creating an index. Because it matters, because a lot of the resources are going to be pulled in. So how we select these districts for intervention becomes extremely critical. And that will also depend what you wish to show or what you wish to change. Number two, I didn't cover that point here. We also find in the data a lot of variation within districts. As I said, a district is a very large entity, about 1,000 villages on average, or about 1 million people. So there's a need for a high-frequency data, but you don't get that much data at sub-districts level or below districts. So I think there is, if you want to do research, then just surveys that are done even annually or biannually is not enough in terms of, for operational research, you want very targeted surveys of just 20, 30 questions, but with a high granularity and high frequency. It's not meant for research, it's meant for operational research. While surveys serve, it's a one-size-fits-all. You can gain insights, but for policy purposes, I feel one needs to rethink about how should that be done. Maybe a triangulation of the administrative data and survey data, but survey alone, I feel, is not enough. By the time it's out and cleaned, it's already dated, and it can't help the policymaker in real terms. A third point I want to emphasize overall is that when we look at these indicators, I've seen presentations, many presentations over the years. Every time we focus on prevalence, percentage of this or percentage of that, whatever that our favorite risk factor might be. But again, I feel from an operational policy, that's a useless number. Because from an operational perspective, what you want is the head count, how many? Because if I have to treat somebody, let's say I have to send vaccines to a place, it does not matter whether it's 5% or 15%. I need to know how many kids needs the vaccine, or how many elderly needs X, Y, Z. So I think even in terms of the metric, we need to move beyond this prevalence, and that's where looking beyond surveys are very important, because ultimately you want to identify the beneficiary. So the beneficiary is the key recipient of any policy, and for that, that's very critical. A fourth point I want to mention, this coming from like the last 3 or 4 years of work that we've been doing with policy folks, when I go to Delhi or even state capitals, they're all very recipient to what we are talking about. The secretary level or the joint secretary level in India, these are very high-level positions. But I think the real support, R&D support on data analytics is required at the district administration level. They do have data, but
Professor SUBRAMANIAN, please now that your time is over, could you quickly summarize?
Sure, I'll just summarize. Yeah. So I think that's a point that I want to just emphasize. So I think I'm done. This is a paper that we have published if you want to see. Just a plug, we have currently we have just sort of wrapped up a big project called the India Policy Insights, where we have 150 plus indicators at 4 levels of geography: district, parliamentary constituency, assembly constituency, which are very small, and villages, about 500,000 of them. Thank you so much.
Thank you. Thank you very much. So he used the India data. It's a huge country, using the selected SDGs and indicators in India. Thank you very much. So now we are behind the schedule, almost 30 minutes behind schedule. So now I'm inviting the next speaker. Who will do that? Professor Sun-Jin Jo. She's from Catholic University. She will make a presentation about community-level intervention model for addressing health issues in Korean local community. So you are given the 10 minutes, please.
Thank you, Dr. Shin, for introducing me. Hello, everyone. I'm Sun-Jin Jo from Catholic University of Korea. I'm delighted to have an opportunity to share about my ongoing project with all of you. The topic is a community-based innovation model for addressing health issues in Korean local community as the NOMAD project as a case study. Yeah, this is in this presentation, I'd like to briefly explain the background of the NOMAD project for reducing high-risk drinking and alcohol-related harm. Next, I'll discuss the community-based environmental change intervention model adopted in the NOMAD project and the strategies employed to implement the model. Finally, I'll present preliminary short-term impact evaluation results before concluding my presentation. Yeah, it's introduction. As you know, Seoul, the capital of South Korea, comprises 25 local autonomous districts, and Jungnam district is one of them, where the NOMAD project was implemented. The population of Jungnam is approximately 400,000, and its financial independence ranks 19th among the 25 districts in Seoul. Recently, Jungnam has faced challenges. For over 10 years, it's ranked among the top 3 in Seoul for the prevalence of high-risk drinking, along with high mortality rates related to alcohol-related diseases and so on. Sorry. Yeah. Yep. Yeah. The Jungnam Public Health Center, feeling limited by services targeting high-risk drinkers, eventually realized that the individual-level approaches were not sufficient and they needed a community-level approach. This led to discussions with an academic group regarding this issue, and I was a member of the discussion group. After some time of discussions had begun, the KDCA has announced a call for selecting local autonomous districts eligible for research funding in in-depth study on local health issue and innovation research. So eventually, Jungnam was selected as a recipient for the research funding, enabling the initiation of interventions to reduce high-risk drinking and alcohol-related harm in the local community. Then what intervention model might have been needed for the Jungnam district? As mentioned earlier, they recognized a community-level approach was needed rather than interventions focused solely on individuals. So we decided to adopt evidence-based models like SAFER by WHO or community trial project by holders and others. We focus on interventions feasible at the community level, except for interventions feasible at the national level, such as taxation policies and so on. And in response to demand from the public health center, additional interventions such as school prevention education for children were incorporated. But doubts arose regarding whether environmental strategies could reduce not only alcohol-related harm, but also high-risk drinking. So we analyzed the correlation between the time series of high-risk drinking prevalence and the variables of alcohol-related harms. And the results, they indicated that applying environmental strategies is worth considering for our purpose. So we've taken the shape of the Jungnam community-based intervention, environmental change intervention model. The left part of this picture is the main model based on evidence-based interventions, and the right part is the expanded model reflecting the additional needs for the public health center. Let me take a quick pause. I'll show you the poster we've been using. This is our standard poster template, and we've customized those white letters to suit the special resources involved. Our project is named No Mad, No More Alcohol Drunk. Returning to the main topic, the Jungnam community-based environmental change intervention model has been established like that. Now, how were various interventions implemented? This is where collaboration comes in. Collaboration among community resources, each possessing distinct originality like pieces of this puzzle, is crucial. We first identified public and private organizations or entities to implement each intervention. The next step was meeting with each community resources and convincing them that their action could make a difference in this area. Providing some evidence seemed crucial. When they asked, "Can this really work in our community?" Then offering evidence-based information was definitely helpful in persuading them. We ensured that each resource had a defined role reflecting their unique expertise. For instance, when the police conducted a campaign against drunk driving in school zone, the local medical association was not asked to participate just because they were involved in community collaboration. The role of local community association was clearly defined to intervene in high-risk drinking cases directly related to patient health at their local clinics. I believe this is one of the crucial attributes needed for sustainable collaboration in my country. Subsequently, memorandums of understanding were signed. This picture is one of the press articles reporting on the MOUs. Thus, the Jungnam Alcohol Use Environmental and Cultural Improvement Partnership was launched under leadership of the district mayor, involving public resources such as the council, police, or education office, and private resources like medical association and the Korean Food Industry Association, and so on. Afterward, operational team was designated within each resource, enabling discussions to work out the details of the interventions together, leading the implement of the interventions. This is a simplified example on how frequently we met the community resources. I just wanted to show you that the collaboration in Jungnam is not just in name, but the one that actually functions and operates. So far, we've briefly looked into the NOMAD project and the collaboration among resources within the local community. Now I'll show you the preliminary analysis results. Given that NOMAD projects kicked off in 2021, we would all agree that there is limitations in evaluating and interpreting its impact right now. So I'll show you just 2 outcomes as samples today. First, it's about the prevalence of high-risk drinking, the primary outcome. Based on the community health survey data from the KDCA, we observed a decline in high-risk drinking prevalence in the intervention group compared to the control group after the intervention. By calculating the change in each district as a percentage relative to period before the intervention, we found that while the control area experienced an average 7% increase, the intervention area showed an approximately 11% decrease. Secondly, this slide shows a result obtained from another data set collecting using this method described the left side. Compared to 12 months ago, there has been a significant decrease in the prevalence of being a passenger in a vehicle with a driver under the influence of alcohol in the intervention group. Now, wrapping up my presentation, I'd like to discuss the implication of my study. The NOMAD project marks the initiation of environmental change strategies to address alcohol-related issues at the community level in Korea. Those approach is highly significant in 2 aspects. First, it is based on cross-sector and multi-resource collaboration. And second, such collaboration demonstrates the potential to impact alcohol-related problems in the community. Actually, this is the 3rd year since the NOMAD project kicked off, and the financial support for this project will terminate in December of this year. I really hope that the collaboration continues in this area, Jungnam, even after that, enabling a longitudinal evaluation of its impact. This could potentially provide an evidence for more communities to initiate similar collaborations within their region. Yeah, this is my last slide. Thank you.
Thank you, Professor Jo. I'm very glad to hear that your approach with the whole of district government and also the whole of district stakeholders are getting together and then make efforts to improve your disparity. Thank you, Professor. Now I would like to last speaker, Professor Kwang Kee, who is now the invited professor of Ewha Women's University. Dr. Kim, it's your floor. Yeah.
Good afternoon. Thank you very much for your nice introduction. I'm going to talking about the community empowerment to address inequality in obesity through community engagement, a case study of Seong City. I'd like to thank KDCI having me a chance to share my project in Seong City. I'm going to make a presentation in a very brief way because I have a very limited time available, 10 minutes. These are colleagues who are very passionate and excellence in the project. Background of the project, health security is set as being of national importance. Overarching objective of health plan HB23, which is equivalent to healthy people in US, include promotion of health equity. But at the local level, local government is a very early stage to deal with this issue. However, the KDCI has, I believe, the leader to identify best by policy model being applied to promote health equity between small area, which means neighborhood within a city level. Seong had been funded by KDCI as a city to address a difference in prevalence rate of obesity between neighborhood, Mokgamdong on the project, and Eunhaeng-dong. The Mokgamdong is a relatively new developed suburban bed town neighborhood consisted of high-rise apartment complex and old-fashioned flat house with limited public transportation available. They are very young in terms of population structure. They are about 50% population is in age of 30 to 50. Population size is more than 40,000 residents and increasing trend in size. Seong Community Public Health Center has established a Reach Out Center and Mokgamdong so-called Jungbu Center to support for health lifestyle. India University Graduate School of Public Health had joined to support the 3-year project in terms of planning, implementation, and evaluations. We have two objectives. One is to reduce the gap in prevalence rate in obesity between Mokgamdong and Eunhaeng-dong. The other one is to develop materials to translate lessons learned into practice for the other neighborhood reach-out centers in Seong City to use. These objectives in operational definitions. First year, we have various, we employed various methodology to identify the determinant of obesity and community asset the Mokgamdong has in terms of socio-ecological model. We recognize the determinant of obesity in Mokgamdong as consisting of health, eating behavior, physical activity, lifestyle, including sleeping time and screen time. Also, we had found to have a community organization with which the community engagement model was able to operate and increased in social capital. Taking this community diagnostic information into consideration, we developed a working model for implementation, so-called community engagement. They are derived from the theoretical perspective, just like setting approaches, social marketing, community organization. With this model, we assumed the city is going to be a place with health environment in which everybody has everybody was given more chance to be healthy. This is a component of the model we developed. As you can see, we have 59 programs in 10 areas, which is a very big one, including health promoting apartment, health promoting kindergarten, and community organization, things like that. For research design, we have pre-post tests with experimental and control group, and also we have the aim framework to evaluate. The second year, during the implementation period, we had the COVID-19 pandemic barriers, which is a social distance policy and human resource management policy. So we have to modify the model, reducing to 39 programs in 10 areas from 59 programs. This is also, we implemented during the January 2021 and through the September 2022. These 10 areas and some list of programs we did. This is a snapshot of the progress implemented. And the third year, 2022, we have an evaluation framework, and we set criteria within the aim framework. We did DID analysis to evaluate efficacy of the model in terms of performance indicator. These are some the criteria and objective of the aim framework. I'm going to skip. Here we can see the DID analysis indicate difference in prevalence rate of obesity and rate of walking regularly has decreased within between two neighborhoods, but rate of taking less salt is become wider gap. I'm gonna skip these two. Okay. This is material for division of the project. The conclusion, overall objective of the project was successful in achieving reduction in prevalence rate of obesity. Also, this is accounted by increase in rate of walking regularly. We have some challenging. I want how to sustain the program implement without the technical support by academia. I'm not sure that it continue to operate without technical support from experts, because of workforce with being familiar with the biomedical model. Also, we have a human resource management policy on job circulation system in community public health centers. We have some lessons learned. Health inequality between neighborhood within a city would be reduced with intervention based on well-designed socio-ecological model, which is a community engagement in this case. Community public health centers should be supported by experts from academia to address health equity within a city. Informed workshop or training workshop are required for civic servants at centers and community leaders with biomedical model to understand community engagement model. Thank you.
Thank you very much, Professor Kim. You just skipped several slides, but I think the main conclusion is that we really need technical support from academia as well as financial support and also empowerment of all our members, the STEM members. Thank you. So we now finished our speakers' presentation. Now we want to move to the panel discussion. We have two panelists. One is the Professor Lee Young-sung from the Chungbuk National University, and second panelist is Dr. Akeem Ali, and Head Office of WHO Asia Pacific Center for Environmental and Health, located in Seoul. So may I ask you, both of you, about about 2 points, only 2 points, sorry, because we are behind of the schedule, 2 points about the lessons learned from this session. So maybe we will have a chair here, or how we can operating of this panel session. Okay, in this regard, okay, can I ask, Professor Lee first, and then.
예, 방금 소개받은 이영성입니다. 오늘 지역사회 단위에서 이 소위 보건으로 불평등 문제를 어떻게 접근할 건지에 대한 전략에 대한 이야기입니다. 제가 지난 20-30년 동안 경험한 두 가지 포인트를 요약해서 말씀드리면, 하나는 우리가 흔히 지표로서 이야기하는 그 작은 집단, small area variation에서 말하는 인디비주얼 단위에서의 지표와, 그리고 population 데이터에서 던져주는 어떤 그런 거를 어떻게 잘 조화롭게 그 갭을 줄일 거냐가 핵심이라고 봅니다. 최근에 코비드-19 크라이시스에서 백신을 맞고 사망을 한 사례에 대한 보상 문제에서 우리가 지극히 과학적인 접근은 population 데이터밖에 없다. 의외로 그 한 개인의 인디비주얼에서의 이벤트를 설명할 많은 그 지표들이 필요한데 그 부분은 많이 모자란다는 거죠. 이 부분을 특히 커뮤니티 레벨에서 어떻게 해결할 거냐, 저는 거기에서 지역사회 주민들의 참여를 끌어낼 게 대단히 중요하다고 생각합니다. 소위 커뮤니티 파티시페이션을 하기 위해서는 소위 지역 단위의 소위 컨텍스트를 읽어야 하는데, 아시다시피 대부분의 의료 영역에서의 많은 흐름은 메디컬 모델, 서양과 유럽과 북미 위주의 지표들로 구성된 집단의 어떤 데이터를 가지고 접근하는 게 한계가 있습니다. 이런 부분에서 저는 소위 커뮤니티 파티시페이션을 이루기 위한 접근 방법 중에 동양적인 접근이 대단히 중요하다. 마치 동양인이 갖고 있는 컨텍스트에 흔히 우리가 말하는 체면 문화라는 게 있습니다. 바로 이런 집단이 갖고 있는 나 개인의 어떤 이해보다 집단이 갖고 있는 이해에 대한 것을 좀 더 집중하면 많은 스몰 에리어 베리에이션에 대한 문제를 풀 수 있는 어떤 해답을 찾을 수 있다. 인도, 일본, 한국 다 이 아시아지만 그 아시아 속에는 나름대로의 문화의 차이가 있고 그거를 좀 해결해야 되겠다라는 게 첫 번째로 말씀드리고 싶은 포인트고요. 두 번째는 오늘 많은 분들이 언급을 하지 않고 계신데, 소위 디지털 또는 스마트 시티에서 우리가 데이터 드리븐 헬스 팔러시를 하기 위해서 꼭 짚고 넘어가야 할 부분이 인디비주얼, 굉장히 민감한 개인의 정보를 가지고 만약 영리적인 회사나 영리적인 목적으로 접근할 때 그게 생길 수 있는 어떤 문제를 어떻게 우리가 극복할 것이냐, 이 부분이 대단히 중요합니다. 바로 며칠 전에 챗 GPT를 만든 오픈 AI의 대표이사 샘 알트만이 해고됐습니다. 아마 그 비하인드 스토리에는 아마도 통제할 수 없는 과학기술의 발전에 따르는 엄청난 위험을 어떻게 대응할 것인지에 대한 문제로 아마 그런 사건이 벌어진 걸로 알고 있는데, 마치 우리가 핵무기 개발에 있어서 오펜하이머가 고민했던 그런 문제를 지금 시대에 고민하지 않을까. 저는 스마트 시티나 디지털 시티라는 어떤 그런 화두로 더 어쩌면 불평등 문제를 해결하기 위해서 접근하는 그 개인들이 스마트 시티나 데이터 드리븐 헬스 팔러시에서 오히려 피해를 보는, 마치 영리회사, 제약회사의 실험의 대상이 될 수 있을 수도 있다는 그런 위험에 대한 것을 우리는 반드시 인지하고 거기에 대한 프로텍션 할 수 있는 메커니즘도 함께 개발해가면서 이런 논의를 해야 된다고 생각합니다. 이상 두 가지 포인트를 마치겠습니다. 감사합니다.
감사합니다. Thank you very much, Professor Lee. And may I invite Dr. Ali?
Thank you very much for inviting me to join the discussion today. It's a very important subject that I could talk for days on. keeping it to 2 points, I think the starting point is understanding the nature of the problem enough. And that's come from all the various conversations we've had about surveys and looking at headcount burden, going beyond prevalence data. Once we understand the size and the nature of the problem, then we've got to do the right things by translating that knowledge into action right at the forefront. And for me, if you ask me to pick a very critical part of doing what's the right thing to do, is that to deal with inequalities, you don't just focus on the most disadvantaged. You have to work across the whole population spectrum, work across life cycles, and across all ages. Nonetheless, if you're going to pick your best buy, I would say that you make sure that every child starts with the best opportunities in life. That is the best investment we can make in a universally proportionate way as we deal with the issues of inequity. I'll leave you with one other specific issue, which is that, yes, the medical model might be deficient. However, the access to services that are important to health and well-being is a very critical and necessary thing to tackle when you're dealing with inequalities. Because as one of the professors showed, yes, you can have public health services and other services around. If people can't reach it easily, if people have difficulty in accessing it because of culture, age, ability level, etc., then you would have been doing them a lot of disservice. So for me, it's about universal proportionalism, life costs, starting with children, and making sure people have access to the right services when they need it most. Thank you.
Thank you very much. So excellent panel, the two panels we did. Let me have a conclusion of this session. So in order to develop the strategies to tackle health inequities at the community level, Professor Lee also emphasized community participation. So in order to do the community participation, we need to have a very accessible to the services, as Ali mentioned. And then now we heard from the Japan, India, and Korea, but Japan case, as a highly aged population, you approached of something, the social model, population-based approaches. And India, you use the SDG, selected SDG goals and indicators. So why not? We can consider in Korea's presentations from Korea, we didn't hear about the SDG and indicators. So in Korea also we can utilize the SDG goals and targets and indicators to tackle the health inequalities in the community level. Thank you very much all the participants and the audience in here, and the special thanks to the speakers and panelists. Thank you very much. And then Professor Bang Nore for the congratulatory remark. Thank you.